The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. And again, welcome to our November 6th Safe and Calm webinar. This is Deanna Mitchell with LeadingAge, Michigan. We find ourselves again at the end of a very busy and hectic week. And of course, we've noted that across the past week, the COVID numbers keep rising. This morning, we have a few updates from Dalton about what is happening in the policy world, and we will briefly review the Michigan numbers and finish with a review of new resources. Over the past week, we have received a lot of questions about both testing and visitation, and so we'll be focusing on and summarizing some of those major issues today. We also want to note at the start that we fully understand that there are a lot of questions out there about nursing home point of care reporting through NHSN website. So we want everyone to know up front that we currently do not have answers for those questions. And so we're going to ask the members be patient as these issues are addressed by CDC and CMS. So with that, we will turn the presentation over to Dalton, our Director for Public Policy.
Good morning, everyone, and welcome to today's Safe and Calm call. Today, we'll be going over a little bit of what the Michigan landscape looks like post-election. We'll be covering some of our advocacy topics and some of the next steps for our advocacy in the state and what we're kind of looking to get done in the next little while here. I feel like the theme of the week has been unknown, and even maybe the theme of the whole pandemic period is the unknown. So we'll be covering a little bit of our advocacy efforts in the middle of this. And then lastly, there's going to be some updates for our webinars going forward, the Safe and Calm webinar series, and what some of the issues have been with our website and what we're doing to resolve those. So let's start off with a little look at what the landscape in Michigan is going to be for the next 2 years until the next election. In Michigan, Republicans kept control of Michigan's House of Representatives. Prior to the election, there was a lot of hope from Michigan, the Michigan Democratic Party, that they might gain control of the House. That did not pan out, and Republicans held a majority in the House. And so they will now have a 58 to 52 majority. In fact, that's the same number as it is right now. So expect a lot of kind of the same, at least, functionality from each part of the legislature. Rep. Jason Wentworth from Clare will be the next Speaker of the House. And he'll be working with Senator Majority Leader Shirkey to form kind of the Republican legislative advocacy team. Another thing that's important to note is that all existing legislation will sunset on December 31st and will need to be reintroduced in each chamber. This is just kind of a procedural thing for the legislature. Every time a new legislature comes in, or not every time, but every couple of years, the legislature will reset to give everyone, to kind of refresh and give everyone, the new people, a shot at what legislation they think is important. And so you won't see everything reintroduced, but a lot of it will be. Our expectations for the next 2 years, we expect similar budget negotiations to last year, except this time they'll have a bigger budget deficit, is what at least is being projected right now. And at the moment, less CARES Act dollars to fill that budget, but we'll see what happens on the national level in regards to that. The lame duck period we expect to be quite slow and pretty sporty, so we expect to see a lot of things kind of out there for show or for political reasons, and then them to make a big stink about it, but nothing actually move because of the divided government that is going to be in place in Michigan and that is currently in place in Michigan. So moving on to kind of some of our advocacy asks of policymakers in Lansing. we've been working on a number of topics, and we've been taking into account your questions and concerns that have been forwarded to us through this webinar and other processes, and just kind of the general landscape of what's going on in Michigan. And we feel that submitting a formal written piece of advocacy to policymakers is going to be important. Right now, we have 5 main focuses for this piece, and I'll provide some context for each of those. So first off is the CRC rules, which if you were on yesterday's policy call, you'll have noted that they increased the monetary benefit to becoming a CRC, and I have attached the application and the adjusted application, that is, to the handout section of the webinar. There is a November 15th date for the department to provide what these rules will actually be. They have some loose guidelines right now that are kind of restrictive, and the department is supposed to provide guidance on these, and they have yet to release any of this. Some of our major concerns on this is that it doesn't really address the issues of HFA and IL and where they stand in the kind of long-term care COVID landscape. And then it also restricts the ability of facilities to admit their own residents. We've heard from a number of members and that this is important. And we also feel that it's important. So we'll be asking the department to comment on what their plan is for this. Another issue that was raised on the national level and was encouraged by LeadingAge National and many other states to see what each individual state can get done is including senior housing providers in the vaccine distribution prioritization. As you know, right now, SNFs, CCRC campuses, assisted livings are prioritized in the vaccine distribution, the COVID-19 vaccine distribution plan as it stands. We don't know exactly what will be going on at the national level yet, but the senior housing was kind of left out of the discussion entirely. So we're going to be advocating on behalf of senior housing providers to see what we can do in terms of vaccine distribution. These slides are in these priorities are in no particular order. I just wanted to put testing and visitation on the same slide because they go hand in hand. Right now, we know Michigan is still not following CMS guidelines in regards to visitation. And we also feel that because of the county positivity rates they have set, that they're essentially, this second wave continues to ramp up of COVID, that there won't be any visitation. They'll have it in name only. And we do feel that is a problem because of issues of mental health and isolation. And in a positive note, kind of on the testing line, we did reach out to Director Gordon and Director Massey over the last week. And yesterday, Dr. Gordon reached out to us and said that he's going to be following up with Laura in regards to testing of surveyors. He had understood that something was going to get done and was kind of surprised that we had not heard anything. So expect some news on that front soon, not just surveyors, but departmental staff who are going to be entering any kind of long-term care setting. We have heard your concerns on that, and they're very understandable. Then lastly, just in general, as we face almost, I would say, more unknowns than we have before, because there's guidance out there, but it's not always clear. We just are asking for clarity for long-term care providers and staff. We know everyone is doing their best every day to meet guidelines and provide quality care for the residents, but we don't necessarily feel the state is giving everyone the clarity they need to provide quality of care. So we'll be asking them to just maintain clarity and open communication and hopefully improve it a little bit going forward. So moving on from advocacy and kind of changing hats here for me, the Safe and Calm webinars, as you know them, are still going to be happening on Wednesdays and Fridays at the exact same times. But we have experienced some technical issues. I'm sure some of you are aware. On your attendee webinar link that is sent out to you, the time has been wrong and maybe even in a different time zone. And we have researched into why this is, and this is because this webinar series has been going on for so long, and we've added so many dates here and there and changed times and everything, and now the webinar link just needs to be refreshed. So we are asking everyone to re-register for the Safe and Calm call. I will be reaching out to everyone who is currently registered for this call and sending them an email with the link for the new webinar. It will all be happening at the same time, as I said, but you will just need to re-register for the webinar, and this will fix the issues of the times coming out wrong and not being able to be exported to your calendar because it says the wrong time and all of this. So your link will be changing. I will be sending that out to everyone individually, and I'll also be pushing this through the listservs and through other means of communication. And that's kind of it for that. Moving over to our website, we do know and apologize for many of the technical issues. This has been from an on-site from our national website hosting provider. They've been experiencing some bot attacks that have overloaded their servers, which is causing service interruption on our end. They're working on those issues pretty diligently. They've been expanding their team. They're working in coordination with Microsoft itself to rebuild everything. So we do anticipate these issues to be resolved shortly, but we know it's been about a week and a half, and I do encourage you to reach out to me or to other team members if you do have any website issues or you need something off our website or you're just looking for any information. We're always available. This is our important date slides. A couple of things I did want to point out here. You'll notice it has shrunken a little bit because there was a lot of things due on the 31st of October. Going to that October 31st date, the deadline for MDHHS to distribute the SNF PPE reimbursement payments was on the 31st. These are the payments that are automatically sent to SNF providers. There was no application process needed for these payments. I sent out an Excel sheet on the SNF listserv and also attached it to this webinar series on the last webinar for providers to see the exact amount they should be receiving. If you are looking for that Excel, please contact me, or if you have questions about this, please contact me. But just know you will be seeing some funds from the state come in for PPE reimbursement that you may not have applied for. It's an automatic process, and every SNF in the state is qualified who has licensed beds. And then also, today is the last day to apply for the Phase 3 Provider Relief Fund applications at the national level. I believe I saw a slide in here that Deanna will be covering later, so I won't go into too much detail there, but just know that that deadline is today, and you can see the other deadlines coming up as you go down the chart.
All right, thank you very much for that, Dalton. Before we get into any questions, each year, LeadingAge Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. So we do have a couple questions here. Dalton, governor press conference yesterday, she indicated that vaccine would be for communal senior living. Does that not include IL?
I was honestly not aware of what she said there. I missed that press conference, unfortunately, but we will see clarity on what exactly she was saying. I understand the concern for your question because that's pretty vague language. I would hope that would include IL and housing. So maybe some of our inroads have been successful. I'll follow up on that. Thank you.
Okay. And then this is just a follow up from that. She also said healthcare workers. Would this include our staff? So I'm sure you will follow up on that as well. And then one question for Deanna, actually. Deanna, you were referring to the POC reporting for SNF doing POC testing. Is that same reporting required for HFA that have the POC? I know this area is not being discussed, but wanted to understand it if the issue rolled over into HFA.
No, we were really specifically speaking to the NHSN requirements for point of care testing for nursing homes. I'm actually not sure if HFAs and AFCs can use that system as well if they choose to, but it is definitely not required at this time.
All right, and it looks like that was the last question, so we can move forward.
Okay, so as usual, we're going to do a quick review this morning of the numbers. I do want to note that during the governor's press conference yesterday, Dr. Caldoun, who is the Chief Medical Officer for MDHHS, announced that 50% of COVID positive persons have no idea how they contracted it at this point in Michigan. So that's a real concern because that means that the virus is really spreading at what they would call a community level, and it makes it very hard to track and contain it. So yesterday's press conference was pretty much another warning about the spread of COVID in Michigan. And then over the last week, the 7-day rolling average of new cases did rise again significantly. If you look at the arrow on the right of the graph, you'll see that it's pointing to the level of daily cases as of last Friday. So we've seen a significant increase from just last Friday. The number of daily deaths, though, has decreased just a little bit from recent numbers over the past week. And although higher than during the summer, remember that these are actually raw numbers. They're not percentages or anything. So considering the remarkably increasing caseload, the death rate still remains fairly low. But the average daily death, is hovering around 18 to 20 on a 7-day rolling average basis. And over the last week, the MySafe Start map has turned darker all over, with all regions now at either a D or E level, which are both considered high risk. You can also see from the numbers that our test positivity rate has gone up in aggregate all the way to 8.1. If you remember, about a month ago, we were at 3.5, and we hovered around 3.5, 3.3, 3.5 throughout the summer. And we have 267 now new cases daily per million. And about a month ago, less than a month, maybe 2-3 weeks ago, we were at 112.4. So things are going up. One of the things to remember is that each county can vary from their regional color codes, and that this map only displays the regional color for risk level. Also over the past week, the department started posting new cases separately from cumulative cases for nursing homes. And you can see that the reporting also now includes HFAs and AFCs. This data that I looked at yesterday was only of November 2. So as of the 5th, they were still reporting data as of Monday. And not all HFAs and AFCs have registered yet. And are not yet reporting. But they did hold an additional registration day last Wednesday, and there is now some current data, and not just only cumulative data published for these entities on the MDHHS website. So let's move on to a discussion of guidance and some other resources. And as I said before, we're going to spend a bit of time in detail looking at testing and visitation issues. So our first piece is about the provider relief applications. There was a webinar, I believe, yesterday about this. There is an HHS webinar recording. I'm not sure if you can get the link from this slide. We'll make sure we send it out with the video for this because it's an important piece to listen to. They changed some of the pieces again. The bottom line for this is to remember that phase 3 applications are due today. So you must submit your tax identification number for validation by today if you are expecting to apply for any additional funds. They do continue to process these validations and for phase 2. And upon validation, those providers will be given an opportunity to complete the phase 3. So one of the issues before was that some of the phase 3 applications were blocked because the phase 2 applications were still open. So there was guidance before that providers might have to cancel their current phase 2 application in order to submit one for phase 3. But now HHS is saying don't do that. So for next steps, they should be coming soon. And we encourage anyone who is engaged with the grants to watch the HHS recording. The CMS Resource Center last week, during this week actually, CMS announced a new website intended to provide easier access to all the COVID resources. It still takes several clicks to get to where you need to go from here, but it does provide a starting point for those who might not be familiar with finding the regulations. We did participate in a call with MDHHS yesterday, and so we want to provide updates as a result of that call. One of the topics, actually the major topic, was the development of care and resource centers. Currently, the department is a bit concerned. They still have no applications for regions 1, 5, 7, or 8. Region 1 includes Detroit. It's called Detroit, but it actually covers most of Southeast Michigan. The counties are listed there. Region 5 is Lansing, and the 5 counties close to Lansing. Region 7 is Jackson and includes 3 counties, and of course Region 8 is the entire Upper Peninsula. So there are no applicants at this point for those regions, and with the surge increasing, the department's a little concerned about that. At the same time, over the past several weeks, we've heard from the communities, from our communities and the department, that the few regional hubs that are left have little capacity left. The department, again, is concerned about finding places for COVID positive persons, considering the recent viral surges. 2 CRCs were approved yesterday, although they didn't tell us who they were. And 1 more is in review and close to being approved. And we believe that there are 2 more awaiting LoRa site visits. So there's a total of 5 in the process right now. One of the issues that has come up is the fact that CRCs are expected to hold their beds open for COVID if they are obviously receiving funding and support for those beds, even in times when caseloads might decrease. So you're expected to hold those beds open. That's the reason why they provide a monthly payment to assist with reimbursement for that. But an additional issue is that holding these beds open could put some facilities below the 85th percentile. And so the department is currently in the process of writing guidance to relieve CRCs from that potential reimbursement burden. The department has also revised its financial offer to CRCs. They have doubled both the initial one-time payments, as you can see here, based on the number of COVID beds that are approved, and they have also doubled the monthly stipend. On top of that, facilities are still allowed a bonus payment of $200 per day for each COVID resident, and that is on top of their payment from Medicare, Medicaid, or any other payment source. We have brought up the issue that $200 a day when you're already over the VCL could be perhaps not as lucrative as one might think, and the department said that they would look at that. So the CRC application has been updated to reflect these reimbursement changes, and the link to that is noted at the bottom of the slide. Additionally, yesterday, the department noted that there had been some problems with providers accessing their rapid response staffing program. And so they announced 2 additional contractors will be added to improve responsiveness to facilities who might find themselves in a staffing crisis. The guidance and process to access this program are on the MDHHS website under the Long-Term Care Facility COVID Plan. And documents there have been updated to include these 2 agencies. The department also stated that although they're trying to assist with staffing, it may not be possible to be able to help everyone, considering the ongoing staffing challenges that exist across the state. The CDC issued a few updates during the past week, and they made some small changes to their infection prevention and control guidance for healthcare personnel, and that was as of November 4. So they added a bit of new language around screening, use of thermometers, ventilation systems, and PPE FAQs. The CDC webpage for infection prevention control also contains links to essential guides. And since they updated this entire page, we are listing them here as a reminder. But most of these guides have not been updated recently at all, with the exception of perhaps the risk assessment and restrictions for staff. And in that guidance, they only updated the definition for close contact, which we all know now is 15 minutes over 24 hours, not 15 minutes at one time necessarily. So the links for these key resources are here, and just for your convenience if you want to look at them and refresh. So for under screening, CDC is encouraging outdoor screening whenever possible, but they also understand that there are weather limitations to that perhaps. And they're also recommending the use of an electronic system for screening prior to arrival to the facility. And they finally included this. We have long had a question out to CMS and CDC about electronic screening systems, and there is no prohibition for them. It may not be possible or practical for outdoor screening, as we know, for very long. However, they have provided these recommendations as options. And one of the issues with outdoor screening, at least during heavy winter weather, is that temperature readings could be easily affected. The CDC specifically noted in this update that when surroundings are extremely hot or cold, the body temperature could be affected. And that could happen regardless of what kind of thermometer you might be using. So they don't provide any specific guidance to address this problem, but it's something you should consider when you are screening, if you're doing it out of doors especially. They also remind us that electronic thermometers have to be calibrated. There's some concern about the consistency and accuracy of some of those thermometers because it's very important here. And that non-contact infrared thermometers must be held specifically an established distance to be accurate. So there's been a lot of issues with accuracy when using those types of thermometers. Another new section of the CDC infection control guidance speaks to engineering controls and indoor air quality. They also remind us that movement through the facility should still be controlled during the pandemic, and define pathways and potential physical barriers might be needed in certain places. The guidance also speaks to the recommendations that facilities look at their air handling systems, especially considering now that there are cases that appear to be contracted from airborne transmission. They suggest that there could be some portable solutions for air quality management. And in this section, they included links to guidance on ventilation systems, and those links are included here as well. And last but not least, there was some very small updates to this webpage on infection control, the CDC infection control guidance, and it includes now a link to the PPE questions and answers. We could not see that there's been any real change to those QAs, but it is a resource on proper PPE use as a reminder. There was also a reminder here that considering the continuing need for PPE, they anticipate that shortages could come more so than we might have already, and that facilities should be working first with their local public health systems if PPE becomes harder to acquire. And lastly, there was a brief change in the language. I couldn't really see a change in any process, but a brief small change in language about the process to obtain anterior nasal specimens. And you can review it on this guidance, but again, we didn't see any significant changes there. The CDC also, in the past week or so, updated its guidance for retirement communities and independent living. And this might be important because it, at this point, would be the most comprehensive guide for these settings now that the department has eliminated them finally from guidance for residential healthcare facilities. Basically, the new language focuses on accepting and admitting new residents and how to support residents through the pandemic. Some small changes really only, but it is pretty much a good guide for independent living and other facilities of those types. So now let's take a minute to see if there are any questions before we move on.
All right, thank you, Deanna. Before we get into any questions, each year LeadingAge Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. All right, so we do have a few questions. If we have a contingent staff member who tested at her other place of work test positive and has not worked at our community in 2 weeks, do we also report her as a positive with the county, and do we also have to follow the MDHHS orders on informing others as she has not been at work for 2 weeks?
No, you don't have to do either of those things. As long as they have not been in your building for 48 hours prior to test or symptom onset, they're not considered a facility acquired or staff or a facility staff case. It would be the other facility if she or he has been in that building recently. It would be their responsibility to report that.
Okay. Which facilities had CRCs approved yesterday? We are looking for a bed for a COVID positive resident.
We were actually not informed which facilities had been approved. We can tell you, though, that they're not in Detroit, Jackson, Lansing, or the Upper because there have been no applications there, but we were not informed yet of which CRCs have been approved. We hope to hear that soon.
Okay. This one is decently long, so just so you know. Our county's positivity rate has been over 10% for the last week. However, CMS talks about only checking the positivity rating every other week. CMS posts the county positivity rating, which is a look back from the last couple of weeks. Can we wait to do the twice weekly testing until the positivity rating on CMS is over 10%, even though the local positivity rate shows it's above the 10%? Our lab has not been giving us results in a timely manner, so adding more volume will not help. Are we expected to try to do rapid response tests for the second test each week?
Okay, well, there's a lot there, but let me, if I understand the gist of it, my response would be I would not pay attention and address the CMS requirements. I'm assuming that you're a SNF then, until the CMS color code actually goes red. If it doesn't go red, then I would continue to test weekly. Once it goes red, though, you would be required to do that. And one of the important things to remember here is that your county positivity rate might be greater than 10, but the CMS requirement for a red level of risk has to do with the fact that you have to have enough tests done in your county to register. So it could even say you have an 11% county positivity rate on the CMS website, and it might still be yellow based on the number of tests that you've done. So CMS adjusts those color codes. So I would not test twice a week unless you have some other reason to do that until that color code for your county turns red. Otherwise, MDHHS only requires weekly testing. In terms of point of care tests for the second test, if you're doing it twice a week, you could use point of care tests for both of them. You certainly could use point of care tests for the second test. If you're having a hard time getting your results back through a lab that's doing PCR for you, if it's more than 48 hours, you're out of compliance if you have point of care tests at your disposal. And if you're not getting your tests back within 48 hours and you don't have a point of care test to help with that, you're supposed to be notifying the state and working to do that, because one of the big pieces here is getting results quick enough that you can actually address any COVID positive findings as soon as you can, because that's what limits spread in these facilities.
Okay, this is another long one as well. If a maintenance staff tested positive and eats with other maintenance staff at break time less than 6 feet apart, they all may have been exposed. Can we utilize CDC's optimization of staffing suggestions to keep one of them working? Test them each day with a rapid test and not have them up on any resident care area unless there is a maintenance emergency that they would address. We would have them wear an N95 if they went in any resident care area and move the resident out of the area. Is this acceptable from an infection control perspective?
Well, first of all, I have to put a disclaimer here. I'm not an infection control expert. I do believe that how you decide to use optimization of staff in response to these issues, I think it would be based on a lot of variables and would be up to the facility to consider whether or not, first of all, what is the impact to your facility if you take someone who, number one, wasn't socially distanced. That's an issue right there if they've been eating together. And what is the impact of taking them out of your staffing schedule for a while? That'd be the first thing I would look at. The second thing is that, sure, you can take precautions, but it also depends on what's going on in your facility and what's going on in the community risk area, whether or not you should probably allow this person. It's an individual choice. You can certainly follow the CDC guidelines if you choose to. But you might have to support that later because you could be putting your facility at risk. It's something that the facility will have to decide.
Where is the IL guidance located?
On the CDC website, the IL guidance, we can provide you a link to that. It is on the CDC website. And actually, if you look at, if you go to the basic website and then you have to click on the banner to get to the COVID resources. If you go to the very bottom, there is a what's new section. And they put out 10 or 20 updates every day. Most of them don't apply to us. But if you look in the last week or so, you will see that link to the retirement community updates. And we can also provide it if we haven't already.
Are the 1030 retirement communities IL guidelines from the CDC or from MDHHS?
They're from the CDC. There are no guidelines anymore from MDHHS.
Can you please explain the difference between a hub and a continued care and recovery center? Will hubs be going away if they do not apply to be a CRC?
Can you repeat the second part of that question again?
Can you please explain the difference between a hub and a continuing care and recovery center? Will hubs be going away if they do not apply to be a CRC?
The answer to that is yes, they will be going away, but there's a transition period. The CRC has more criteria. One of the issues was that some of the quality of care and the history of some of these regional hubs didn't seem adequate. They were established very quickly, and there were some issues with some of them, let's just say that. So there is updated requirements now for CRCs. They are a little bit higher. On-site visits, if possible, are required. In other words, there's more than just an attestation from a facility that they can meet all the requirements. However, considering that there are very few CRC applications, some of those regional hubs are going to exist out there, even if they don't meet the new criteria for a while, because there has to be some place to put some of these COVID positive residents whose facilities are very, very unsure about taking care of them. So until we know that there's going to be a lot more applications, we anticipate there's going to be a long transition period here.
Do we know the process for getting a COVID unit approved within our facility, not as a CRC?
No, not yet. The department is required to have guidance out by November 15th. We are very much waiting to see that. As Dalton referenced earlier, we find that the new law for CRCs is extremely restrictive. It's going to be interesting to see what the department does about that. It seems like our facilities have been put between a rock and a hard place for visitation, for care and cohorting of COVID positive residents over time. And so we're working hard to try and address all of this with the department. And so we look forward to that November 15th, if they get it out on time, guidance about CRCs, to make sure that there is a place, a safe place to care for all of these residents.
Where can we find the guidance on an employee who hasn't worked 48 hours prior to testing positive, who hasn't worked less than 48 hours prior to testing positive is not reportable facility acquired?
Well, the guidance doesn't actually say that. If someone hasn't worked more than 48 hours prior to onset, they're not an outbreak for you. So that's the first piece. The second piece is if this person that we were talking about worked in another facility, the facility that utilizes the person the most is supposed to be reporting that person. And considering this person, I was told, isn't working in your facilities, that should be the other facility. If this person only worked in your facility, you would still have to report it, but it's not an outbreak.
Okay. Last question, it looks like. The new guidance is to place all POC into the NHSN site effective November 20 after obtaining a grid card. Is this accurate? This seems like a lot of time to make this occur.
This seems like a lot of time to make this occur. I think you're probably saying this is not enough time to make this occur, but that's my understanding. However, there have been a lot of issues and concerns and questions about this. And to be honest with you, we cannot answer them at this time. I don't even think CMS or CDC has answered them. And so we're trying to work through LeadingAge to get some better answers. And we still have to ask everyone to be patient at this point.
All right. Looks like we can go ahead and move on.
Okay. So this week, the department issued several documents that supported the October 21 visitation order, mostly focused on the associated testing that's now required. for certain levels of visitation. We do know that over the past 2 weeks, HFAs and AFCs are now required to test and report. And 2 dates have been held by the department so far for registration and entry of cumulative data for those 2 entity types. And whenever we refer to AFCs in this context, we're really only talking about those who are licensed for 13 or more beds that would be covered under these rules. So each HFA and AFC will receive an individualized link. So everybody who's registered should already have gotten that. And we include all those links and guidance in our resource guide that we sent last week. And we included them again this morning as a handout for anyone who still may need to start reporting. So when I look at the October 21 visitation guidance, and I've read it, I can't tell you how many times, it's still really confusing, and the infographic doesn't really help me that much at first glance. So since we received a lot of questions about this, we took some time this week to summarize the rules for each category for visitation that is in the MDHHS guidance. And this works a little bit better for my brain. Hopefully it'll work well for yours. If not, we refer you back to the infographic. So starting with end-of-life care, first of all, although we have asked for a definition of what end-of-life care means to the department, because the department developed different categories for compassionate care, they have not responded with a clear definition. So members will have to themselves distinguish between end-of-life care from hospice care and from visits for other persons in critical conditions. That might not be easy, but the guidance is different for these groups coming out of MDHHS. So if you look at it's not really a flow chart, but I guess it's a table. For end-of-life care here, there are very few restrictions. End-of-life visits are allowed at every county risk level. Doesn't matter what your risk level is. And even if there is a facility outbreak, you can have end-of-life visits. Any local health department prohibitions on visitation does not change that either. So visits by clergy for end-of-life should be allowed. Those would be considered end-of-life visits. And if anyone denies an end-of-life visit for any other reason other than the fact that the visitor is COVID positive, you must provide a written letter with rationale to that visitor and also submit it to MDHHS and the long-term care ombudsman. Visitor testing is never required for EOL visits. It is important to note that there's still somewhat a disconnect between the CMS nursing home visitation guidance and what the department is doing. CMS allows end-of-life visits for persons who are COVID positive. We have not received any guidance from the department stating that persons with COVID can receive visits at all, although we keep asking. So the next category includes other types of visits that were allowable indoor visits before the full indoor visitation guidance was issued. We used to call these exception visits. So if you remember, ADL visits, visits for persons in critical condition or hospice were allowed under certain circumstances. So the requirements here differ just a little bit from end-of-life visits. And although these visits are allowed at all regional risk levels, you can be an E, you can still allow ADL visits and these other visits. And they can occur if there's a current facility outbreak. The local health department also cannot prohibit these. But if you're in level C, D, or E, visitors must be tested. These visitors for ADL, for hospice, not end of life, and persons in critical condition, not end of life, those visitors must be tested if you're in C, D, or E. And obviously you can't allow entrance to anyone who may be COVID positive. And again, you have to provide written notice to any visitor within these categories if you're denying them for any other reason other than the visitor is COVID positive. And for both end of life and these categories of visits, you can allow physical contact when warranted, but limited to 15 minutes during each visit and with full PPE. Outdoor visits. Outdoor visits are also allowed at all county risk levels, but they're not allowed whenever there's an active outbreak in your facility. And if the local transmission risk is very high, the local health department does have the ability to prohibit these. No testing, however, is ever required for outdoor visits. Window visits. They are also allowed across all county transmission levels. They are allowed during a facility outbreak, and the local health department cannot prohibit these. No testing is required for any of the visitors, and it's important to remember that facilities must accommodate window visits for any residents who may not have ready access to a window. Medical service providers. They are also allowed access regardless of county risk level, and they are allowed to enter the building even when there is an active facility outbreak. Again, they are not subject to any local health department prohibitions. Testing is required at the same schedule as facility staff. And of course, everyone must be screened, and COVID suspect or positive persons cannot ever be admitted. MDHHS did change, or at least refined, its guidance for non-medical service providers, and it made it different from medical providers, which is the new thing in this guidance. They are allowed for every county risk level other than E. They are not allowed during any outbreaks, and the local health department can, on their own, prohibit these kinds of visits when necessary. When they are allowed, however, these persons must be tested in the same manner as other facility staff. Physicians in training, and that's what the guidance calls resident physicians, and other clinical students have the same requirements as volunteers, so we put them all together here. And although we submitted concerns that we thought that they should be included in all county risk levels, they're not allowed when the county risk level is E. And right now, the number of counties at E is quite high. So these visits also cannot occur during an outbreak, and the local health department can prohibit them, these sorts of persons from entering your facilities. But when they are allowed, as the same with medical providers, they must be tested in the same manner as other staff. So that summarizes the rules pretty much as we know them. And the department late last week issued an updated FAQ. It was only slightly changed from previous. We submitted a lot of questions. It's clear that they're not going to respond to a lot of the details that we're asking for. But first, they did identify that facilities can further restrict visitation, but at the same time, in the same sentence, they state that you still must comply with federal and state regulations. That's kind of a hard scenario to get in my brain, at least, since the current visitation guidance for nursing homes, while it is improved, it still doesn't 100% comply with CMS. So that kind of puts us between a rock and a hard place still. Facilities don't have to monitor visits, as they did in earlier guidance, but they must have a person trained in infection control available. And apparently that person can actually be a volunteer if you're trained appropriately. There's also a reminder here that any visitation for ADL, hospice, critical care, end of life, that are denied must be accompanied by that letter that includes the rationale, and that letter then must also be submitted to the department and the ombudsman. The only reason that does not provoke a need for that letter, if the visitor is denied, is when the visitor is COVID positive. So another question was about 15 minutes of allowed physical contact. Visits do not have to end after 15 minutes, but the time within a 6-foot distance must be limited to 15 minutes. Facilities are reminded that they do have the right to limit the time of visits as necessary for smooth and safe operations, but you do not have to tell the visitor they have to leave after they've had 15 minutes of allowed physical contact. You can allow them to visit as long as your policy requires. They did define resident physician, and it's consistent with what we thought. They restated the implementation dates for each type of entity. You can note that nursing homes should have already complied. HFAs have until November 18. AFCs have until November 24th. Visitor testing is not required in unlicensed assisted living. It's not required in hospice settings, but it is required in settings that are licensed as nursing homes. So if you're a hospice licensed as a nursing home, it does apply to you. And they also confirmed that asymptomatic recovered persons do not have to be tested for 3 months if they're a visitor, just like they would be if they were staff. So this next question is a little hard to describe or to talk about. The question was, are nursing homes expected to provide point of care tests for visitors? And the answer the department said was yes. In other words, pretty much the whole indoor visitation guidance as distributed by the department is based on the concept of POC testing. That's true. It's going to be very hard to do this without POC testing, but technically it is not required, even though there is an expectation, as they said here in the FAQ. If indoor visitation is allowed according to the guidance, facilities who might not allow visitation, especially nursing homes, are going to have some rationale not to do that, because visiting is a resident right. But in terms of visitor testing, it is only required that you actually ensure that they are testing according to the department guidance. So logistically, if you don't have POC tests, this would be very hard. And if you have other avenues to ensure testing, though, there's nothing stopping you from doing that, as long as it works to ensure that visits can happen when they are allowed. It's important to note, it's important to ensure that facilities work to diminish any barriers to testing so that they don't become barriers to visitation. So in other words, if you just wanted to shut down visitation because you weren't comfortable by not allowing testing, I think that would be a risky thing to do. Facilities will be reimbursed for specimen collection time, and an important piece here is that non-licensed staff can be trained to collect the test specimens. I would ensure that you document their training and competency, though. So we had a lot of remaining questions that the department didn't respond to, and we didn't list them all here. One was about visitor testing by PCR. We cannot see where the department would be willing to reimburse for that. So that's another barrier if you think about it. If you have point of care tests, you should consider that. They also did not respond to our concerns about multi-level residential care facilities and how to consider an outbreak in one of their areas, so let's say independent living, as compared to maybe how it might impact nursing home visitation. Although we do believe that a member stated last week that each area could be considered separately, but we don't have any written guidance to that. Again, they did not respond to whether or not facilities can require that visitor testing can be done on their own. And if they have, again, as I said before, access to point of care testing, it might be considered a problem if they make everyone get their own testing done and it limits visitation. They continue not to respond to our question about contractors who need to enter resident areas for non-essential work. If you remember, contractors were only allowed in buildings for essential work according to a previous executive order. It looks like it's still prohibited because we can't find any statements that allow that. But again, the department hasn't responded about it. We are concerned about the fact that some ADL visits, in fact, many ADL visits, would need more than 15 minutes of relaxed social distancing, and the department also did not respond to that. And we assume that cloth, I said that backwards, I'm sorry, cloth face masks for visitors are enough, unless there's a need to exceed the safety precautions for ADL visits or end-of-life visits. And in that case, visitors would need full PPE. We received many questions this week about routine staff testing. And so to try to make it easier for nursing homes, we put together this flow chart. Basically, if you're a nursing home, you should really start with the CMS county color code. And actually, we talked about this a little bit earlier, I think in an early question. If it is red, if that color code is red, remember, don't look at the numbers, look at the color code. If it is red, there's no question, but you have to do staff testing twice a week. If it's yellow, you have to test weekly. So for these two yellow and red categories, based on the CMS Excel file, it doesn't matter what your MDHHS county level, risk level is, the CMS guidance will govern. So if it's red, twice a week. If it's yellow, once a week. The difference comes when your CMS county code is green. Then you have to look at your MDHHS county level. For any level other than low, in other words, if any of those alphabet labeled risk levels, A, B, C, D, or E, are identified for your county, you still have to test weekly. If the Michigan county code is low, which there are no counties at this point in Michigan that say that, you only have to test monthly. So remember, this is just for nursing homes. When looking at HFAs and AFCs, it's much more direct. If you are in a county code of A, B, C, D, or E, you have to test staff weekly. If it is low, you do not. It's very direct and very easy. So a little bit more about testing. This week, the department updated the financial support documents for AFCs and HFAs. They're now posted on the website, and that's the same website that housed the nursing home testing and other requirements. It now includes guidance for HFAs and AFCs, and the link is here. Okay, and finally, we did receive a note from the Bureau that they are planning to improve the CNA page on the Bureau's website. For this is just for nursing homes. They plan to include maps of where all the training programs are. They are looking at updated information about nurse aid registry and testing. So they want to make the site more user-friendly. They have asked for member input into any changes that you might like to see. And we're not sure if anyone really has problems with this website, but they've asked us to reach out to our members. And if you want or have a desire to look at the site, the link is here, and submit any questions to us by end of today. We did put this out in one of our updates earlier in the week. These updates are due to the Bureau on Monday. So let's move to questions.
All right, thank you, Deanna. Looks like we have a list of questions here, so I will just get right into them. Can you send a link to CMS positivity rates we can use for frequency of testing?
Sure. It's off the Nursing Home Compare website, but we can send it out again.
Can you clarify the twice-week testing? Kent County is over 10%, so we were preparing to increase testing, but you mentioned that we don't test unless CMS is in red.
That's correct. That's correct. there is no guidance that says you have to test more than twice a week based on the state. It's only the feds.
Okay. If you have clergy that are on staff with your agency, are they considered staff or non-medical visitors? We think since they are on staff, they can be permitted even in level E. Is this right?
Yes, I would consider them staff for sure. I would not limit them in any way, shape, or form. I can't imagine that anyone would think differently.
EOL does not mean actively dying, correct?
I don't know that. That's part of the dilemma with the department. I actually think it might mean actively dying. The reason why is because they differentiated it from critical condition and from hospice. We asked for a definition. We did not get one. The best scenario that I can come up with in my head is that they may mean actively dying. However, I think that you perhaps could identify that definition in your own policies and procedures because the state has not done it.
Okay, this is pretty similar, but I think slightly different, so I'm just going to ask it anyways. How are we differentiating hospice from end of life? Do we have a definition for end of life yet? Would we need a provider order for end of life?
I don't know that you would need a provider order. And as I said, I think that at this point, every facility is going to have to make a definition that distinguishes between these three categories in their own policies and procedures, because the state doesn't seem to be willing to do that yet.
Is end of life care different than end of life visit?
No, I use those interchangeably.
Okay. So no outdoor visits in C, D, or E?
I'm sorry, can you go back to that slide? Outdoor visits in C, D, or E. I think you can have outdoor visits in all of them, unless I made an error here. Yeah, you're allowed to have outdoor visits in every risk level. What you're not allowed to do is have outdoor visits if there's an outbreak in your facility. Right. Thank you, Blake.
So we are in level E and we can allow outdoor visits. No visitor testing required.
That's correct.
Okay. When should we expect POC tests from MDHHS? Should we be completing a request form?
If you're an HFA or AFC, you should get your first set of tests shortly once you've registered. After you've registered and you've gotten your first set of tests, you should pretty much be filling out the testing assistance form. If you're a SNF and you need more point of care tests, you should be filling out the request form.
Okay. If a visitor tests positive on a POC, will this be seen as a positive for the SNF and then be considered as an outbreak situation?
As far as I'm concerned, no. That is one of the questions that we submitted to the state and did not get a response to. And how to report that is also up in the air. Is that something you have to report? But in no way would I consider that a facility-acquired case. However, since you are the entity doing the testing, chances are you might have to report it. But we have asked for guidance on that, and we have yet to receive them.
I'm sorry, I think I missed how to find out what the CMS county code was.
Okay, the CMS county code is in an Excel file. And it is through a link off of the Nursing Home Compare website. I think it's the fourth bullet on the far left side of the site, down toward the bottom. You click on that, another page will come up, and if you go down to COVID testing, the data, there's a link in that paragraph that goes right to the Excel file that has every county in the United States and I pull out Michigan and look at it separately. We can, I should have perhaps put a picture in here of how to get to that, because we've had lots of questions. We can send out the actual link to that file and more directions of how to get there.
Okay. Can you confirm that AFC's 12 or less and HFA exempt facilities do not have to test staff?
Yes, I can confirm that. HFA exempt facilities are exempt from HFA requirements, and AFCs less than 12 are also exempt from this guidance.
To confirm one more time, we should use CMS site, not Michigan, to determine county positivity rates to determine frequency of testing.
Well, that's not technically true. You have to start with the CMS. If you want to think about it in a logical manner, you have to look at both. But the easiest way to look at it is to know that the CMS guidance is going to drive most of your decision making, except in one situation. So if you look at CMS and you're red, you're going to be testing twice a week. And this is all just for sniffs. If you're yellow, you're going to be testing once a week, no matter what the state says, because the CMS guidance is the same as or higher than what the state's saying. The only difference is if you're green and you're in a low Michigan positivity rate, you only have to test once a month. But if you're in A, B, C, D, or E and in green, you have to test weekly. So you have to look at both, but generally what's driving everything is, right now at least, are the federal guidelines, because they're a little bit higher, except for people in the green category. So it's a little complicated, which is why we made the flow chart.
When did the guidance change to allow for outdoor visits when in E level?
October 21st.
Okay. So if we are testing our residents because of an exposure, we cannot allow outdoor or outside visits?
That's correct. If you have currently an outbreak or 14 days since the last positive person, that's a reason to not allow outdoor visits. And the reason for that, as far as I can discern, is the fact that you have a resident coming out from a facility that has an outbreak and getting close to a family member. So that's why I think that they're not allowed for outdoor visits, but it doesn't matter for window visits, because there's no communication, there's no air movement between those two people.
Okay. In the October 21 order, end of life is defined 4EM as determined and documented by a qualified medical professional.
Oh, I'll have to look at that again. I missed that. So good, great.
Explain again what an outbreak is defined as.
An outbreak, in terms of your response to it, in other words, what you must do in terms of testing and follow-up, is one resident or one staff person. The resident needs to have facility-acquired COVID. A resident admitted as a known positive is not considered facility-acquired, and that's not an outbreak. Any staff person entering your facility during the time of incubation or contagiousness, doesn't matter whether they got it in your facility or somewhere else, is considered an outbreak as well. So one case.
Where can I find the registration form for HFA POC kits?
Okay, you have to register to report first. The link is in the MDHHS testing resources handout. I think it's also on the slide, but it's in the testing resources handout that is included this morning. You have to register to report. Once you register to report, the state will send you an initial set of point of care testing. They'll probably be Binax cards. And then after that, there is a reimbursement form on the website for you to use. It's also a link on there to request further supplies.
Okay. You stated we should expect POC tests once registered. Is this a reporting registration you are referring to, or is there another place to register? We are an HFA, so first experience with required testing.
Right. It's just what I said. It is the reporting registration that the state is using as a confirmation that you're going to need test kits and test supplies.
Okay. I was on the training with NHSN yesterday, and based on my understanding, we are required to enter visitor testing information, testing results into NHSN. There are many questions on how to do this if the facility does not have an ordering provider at the facility.
I can't even begin to respond to the NHSN questions, as I said earlier.
Okay. Deanna, you don't have to start that process at Nursing Home Compare site. You can just Google CMS nursing home data and start there. It is much easier.
Yes, yes. However, I know that everyone knows how to get to the Nursing Home Compare site if you're in nursing home.
On Region 6 call, we heard that Dr. Norelli said she would be the facility's ordering provider.
Okay, that's a possibility. However, the department has said that clinicians, including nurses, can order tests.
Will an HFA or AFC who does not have a CLIA waiver still be sent test supplies after registering?
I'm not sure if the department is checking the CLIA waiver status. However, you are required to have a CLIA waiver, so I'm not sure if you'll get the test in advance. But if you haven't gotten one, if you haven't applied, you should apply. If you haven't gotten one yet, you can talk to HHS. LeadingAge might be able to help because they talk to HHS on an ongoing basis.
So you are saying if we are doing the weekly Qualtrics reporting, we are already registered to receive POC testing supplies. We are an HFA.
Yes, you should be. It might take a little bit. I know some of them have been sent out. I don't know if all of them have been sent out, but if you're already doing Qualtrics reporting, you should be all set.
All right. Do we need consent for COVID testing on residents?
Yes, you do.
Okay.
I believe that you need consent for testing on everybody. I'd have to look into that to be sure, but I believe the requirement is that you get a consent for everyone.
All right, thank you, Deanna. It looks like that was our last question. So if you do think of anything after the webinar, you can always shoot an email over to Dalton, Deanna, or our Safe and Calm at leadingagemi.org emails, and we will make sure to get those questions answered for you. We would like to thank Deanna and Dalton for all the information today, and we would also like to thank the 95 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. We will be sending out a copy of this PowerPoint along with a recording of the webinar, and then we will also send along the handouts that are attached as well in case you didn't get to grab those. Other than that, I think that takes care of everything on my side. I hope that everyone has a great remainder of their Friday and has a great weekend. Get out and enjoy this nice weather while you can. Deanna or Dalton, do you have anything else you'd like to say?
No, please be safe. The transmission's going up, so everyone please be careful.
Have a good weekend.
All right, thank you, and we will see you guys all soon.